Hello and welcome back to AP Psychology here on Educator.com. This time we're going to be looking at abnormal psychology or psychological disorders, depending on which book you're looking at. But we're looking at how people don't fit into the behaviors that everyone else expects of them. So, in terms of abnormal behavior, one of the things that you're going to be looking at is when we see abnormal behavior, it's going to be about 7 to 9% of the multiple choice questions on the AP exam. We're going to be looking at definitions of abnormal, the theories of psychopathology, the diagnosis of psychopathology. So we're going to make ourselves little mini diagnosticians here. We're going to look at a few particular kinds of disorders: anxiety, somatoform, mood, schizophrenic, organic, personality, and dissociative. Most of them probably don't mean anything to you now, but by the end of these segments, they will. And in this portion of the course, we will examine the nature of common challenges to adaptive functioning. So, how is it that we can not be as adaptive and as functional as we need to be in life? This emphasizes formal conventions that guide psychologists' judgments about diagnosis and problem severity. And so there are some both very clear but also very unclear guidelines that psychologists have, and we'll take a look at those. So, defining psychological disorders. How should we define a disorder? That goes back to the idea of operational definitions. How do we operationally define when something is a disorder? How can we and how should we understand disorders? So is there a particular way we should understand disorders as opposed to a way that we should not? And that will make more sense later on. And then how should we classify? And so one of the things, two ideas that I want to get across here before we get into this, because we know that psychological disorders, this is one of the main reasons why most people take psychology. We want to figure out why we ourselves are crazy, why our friends are crazy, why our families are crazy. That's one of the main reasons people take psychology, if truth be told. If we are being totally honest with ourselves, we want to understand crazy. Crazy is not a technical term. It's not a psychological term. It's a pop culture term. But when we look at specific disorders, I want you to focus on the idea of duration of the symptoms, for how long have the symptoms been occurring, and the intensity of symptoms. Are they mild? Are they moderate? Are they severe? So those are going to be two themes that will occur throughout all of the disorders that we look at. But I must give you a warning before we delve any further. You may engage in what is called psychology student syndrome, and that mimics medical student syndrome. See, the third year of med school is when they do diagnostics. When they do diagnostics, that's where they get all the diseases and all the symptoms. And they have to memorize all those. And so year 3 med students oftentimes will become hypochondriacs. They will think that they are getting these diseases. They're not, but they think they are. Psychology student is very similar. When studying disorders, psych students will self-diagnose. And they will start saying, oh, I think I have an anxiety disorder. I think I have a depressive disorder. Oh, I think my mom's got a somatoform disorder. Oh, I think my uncle might be schizophrenic. Or something along those lines. We'll start doing these things where we start diagnosing ourselves and diagnosing other people. Please, please, please do not fall prey to that. Do not assume that just because you think you see a particular symptom that you are automatically, that you have that disorder. And so my recommendation is this. If you have a concern, one, talk to your parents, say, here's what I'm experiencing. Can I see a medical doctor? Can I go see the family doctor? Because if you don't do that, you may be creating some problems for yourself. And the thing that a medical doctor can do is they can rule out organic issues that may be causing what look like psychological symptoms. So this is my advice for all my students, that if they have a concern, talk to their parents. Some of the disorders that we have some online quizzes to help guide you in terms of the symptoms and what people experience. And I will have those in the quick notes. But talk to your parents. And if you're that concerned, get an appointment with a medical doctor so they can rule out something else. As an example, an iron deficiency, anemia, looks like depression. With the lack of mood, the change in eating habits, and the just no energy. And so anemia, that's simply solved. And so you want to get a blood test to make sure you're not anemic. So don't assume that just because you're experiencing something that it's automatically one of these. Please do not make that assumption. What's normal? Well, of course the answer is going to be whatever I say it is. No, whatever my culture says it is really more of the answer that most people will give. But for psychopathology, we need to look at the study of mental, emotional, and behavioral disorders, abnormal or maladaptive behavior. So there's some criteria that psychologists will look at. The first is going to be subjective discomfort. To what extent is the individual feeling subjective feelings of pain, unhappiness, or emotional distress? If you've ever known anybody with an anxiety or a mood disorder, you know that it creates incredible levels of emotional distress. Since that is the case, you need to be understanding of your understanding of the disorder. You need to understand that they can't help it. There is going to be this emotional stress, and they need help dealing with it. So there's going to be subjective discomfort. That's an individual internal perception of what's going on. Then there is statistical abnormality. And an example would be having extreme scores on some dimension. So maybe you are, way out there on extroversion. Maybe you're uber intelligent. Maybe you have an IQ of 145. And so you're out there on the extreme. So you're statistically abnormal. Maybe you have high levels of anxiety or high levels of depression, and that puts you out there on the statistical abnormality. So you're outside the realm of the normal curve. And so statistical. Yes, you've been seeing this a lot lately. And so you've got the mean, median, and mode. You've got one standard deviation, and you've got 68% in here. And let's see, plus 1, you got your mean, minus 1, minus 2, you start getting into the issue of, and plus 2, you might start getting into the extremes of these particular ideas. So, statistical abnormality. I'm not sure what percentage of the population wears glasses non-ironically, but I wear them because I need them to see. And as a result, that makes me statistically abnormal. It's normal for people to wear glasses if they need to. But how many of us are wearing glasses because we actually have myopia or presbyopia? What is normal? Continued. There is social nonconformity. And that's when people just disobey societal standards for normal conduct. This will usually lead to destructive or self-destructive behavior. So these are people who intentionally disobey societal standards. They choose to act in a way that is counterproductive and against society. Fair enough. That's nonconformist. Then there's situational context. The social situation. Does the situation call for particular kinds of behaviors? Does a behavioral setting or a general circumstance in which an action takes place? So one silly example is it normal to walk around strangers while you're naked? Well, if you're in a locker room and in the shower area, completely normal. But if you are, now that I'm thinking about it, as I recall, there was a student, I believe he was at Stanford back in the early 90s. He was known as Naked Guy. And all he wore were flip-flops and a backpack. And he just went from class to class, and he was on campus, and he was just called Naked Guy. And so that was situational context. He violated that. And so that tied into social nonconformity. So was it normal for him to be naked? No, because everyone else around him was clothed. Now, if you were in a nudist colony, yeah, it's perfectly normal to walk around naked. Makes sense. But in terms of most social circumstances, not so normal. Cultural relativity is another one. Now, judgments are made here based on the values of one's culture. So when I first started teaching, was it normal for my students to get tattoos? No. It was incredibly unusual for students to get tattoos back in the mid to late 80s when I first started teaching. Was it normal for females to get one earring or one piercing on the lobe of the ear? Perfectly normal. Now, what is considered normal because of the culture has changed, you have people getting piercings all around the outside of the pinna. They're getting bars that go from one part of the pinna to the other. People are getting dermal implants on their necks, they're getting piercings on their faces, on their eyebrows. They're getting all sorts of piercings all over the place, and younger people with parental okays, they are getting tattoos. Now, when I first started teaching and when I was in college, this was incredibly uncommon. It was not a part of the social norm, but it has become reflective of the values of one's culture. What about facial tattoos? In our culture, it still violates, for the most part, we're kind of okay with neck tattoos. But when it comes to facial tattoos, it still is not totally accepted in our culture. Most places in the United States, you walk around with a face tattoo and people are going to look at you like you're from Mars. Unless you happen to be a Maori. The Maori are the indigenous peoples in New Zealand. And one of the things that they have are the facial tattoos, and they have particular designs that have particular significant meanings as to family background and experiences. And those tattoos are normal within the Maori culture. In the standard American culture, our standard, that won't fit. That is a violation of that cultural value. So while cultures change, I'm not sure that facial tattoos are going to be acceptable working in a corporate office anytime soon. Corporate tends to move a lot more slowly than most places. But if you're working in a cycle repair shop or as a mechanic someplace, then yeah, maybe facial tattoos are perfectly fine because you're not interacting with the public. Not everyone can be a tattoo artist. Not everyone can be Kat Von D and the various other people who do tattoos. It's just not possible. So all these definitions are going to vary by context and by culture in terms of what is normal. Psych disorders includes atypical, non-typical behavior, violation of cultural norms, maladaptive behavior, and personal distress. Now, maladaptive behavior, there's a specific definition for that. And that's behavior that makes it difficult to function, difficult to adjust to the environment and to meet everyday demands. And so, jobs, school, relationships. If a person is not able to, because of their maladaptive behavior, keep a job, be able to go to school and be reasonably successful, and maintain healthy relationships, they may have maladaptive behavior. And that becomes a problem when an individual is attempting to get along in life and do things that are going to be helpful and make them successful. So that's maladaptive behavior. You know that the word mal in Spanish means bad. And so essentially, maladaptive means bad adjustment, unsuccessful adjustment. A mental disorder is a significant impairment in psychological functioning, and we'll see how the specifics are with each of the disorders. And people with a mental illness lose the ability to adequately control thoughts, behaviors, or feelings. And so this idea of control is huge, because one of the experiences that people with disorders have is that they feel out of control. They can no longer help what they do, how they feel, what they think. And this is a huge factor in understanding how people with mental illnesses are experiencing their lives. Why are people behaving strangely? Now, we don't have time in this course or any AP course to go into a lot of depth with this, but I tell you, it's a fascinating history and it's definitely worth some research. The ancient Greeks, it's thought by some that the Oracle of Delphi and some of the other oracles that they had were actually occupied by schizophrenics who were speaking in what was essentially a gibberish, and that the high priests of the oracles were the ones who would be interpreting. So interpreting the messages from what may have been schizophrenics. So essentially, the priests were using a mental illness in order to control the population and people who were coming to them for readings. For a long time, we thought that people were under the influence of magics or sorcery. And so the whole idea of wizards and magic, while it's fun with Harry Potter, what if it's your real life that you think that this is occurring? To this day, people still believe in possession by a demon or by the devil. Some people believe that we are influenced by God to do what we do, and that's why a person is acting in a way that is maladaptive, that is creating personal distress, that is so far outside the realm of statistical normality. We believe for a long time that witchcraft was the cause of people behaving strangely. But by the end of 17th century, and the scientific revolution, we started to realize and understand that it was a physical phenomenon, that there was something going on with our biology, with our brains, and then ultimately with our genetics, that was creating these strange behaviors. So not all strange behaviors are going to be biological and physiological, but an awful lot of them are. And so that's one of the issues we're going to be dealing with in this unit. Philippe Pinel, a Frenchman in the 17 to 1800s, he created a more humane approach to care for and for the treatment of psychiatric patients. Because prior to this, and a part of the treatment of not just why, but also how we treated people with mental disorders, whether it be putting them on the ship of fools, or locking them between the walls of a city, or just locking them away. We treated people with mental illnesses incredibly poorly throughout human history because of what we thought they represented, because of our superstitions, because of the beliefs that we had that were inaccurate as to what was causing these issues and these behaviors. And then he started, that is to say, Pinel, he advanced the categorizing of mental disorders. And so he said, we need to start categorizing, classifying, and putting understandings on and labels on these issues. And so he's known as the father of modern psychiatry. And he also wrote about a condition that was known as dementia praecox, and that now has the name of schizophrenia. When I first started teaching psych, dementia praecox was always parenthetically mentioned next to schizophrenia. Now I rarely see it. So Pinel helped bring about the medical model, the concept that diseases, and in this case psychological disorders, have physical causes that can be diagnosed, treated, and in most cases cured, often through treatment in a hospital. And so this whole idea of the medical model, has been a huge aspect within psychology and psychiatry, because the medical model is used by psychiatrists. Sometimes when I'm talking and writing at the same time, I can't always do both. So psychiatrists will use the medical model. And so if they're having these symptoms, what drugs can we prescribe for them? Disorders, the biopsychosocial approach. So this combines three different approaches. So the biological, the psychological, and the social approach. It's the interaction of nature and nurture, so it's not just biology. It looks at the influence of culture on disorders. And there's a book that I recommend. It's called Crazy Like Us. It came out a couple of years ago. And it's about how distinctly American disorders are being essentially shared. There's a process known as cultural diffusion in sociology, but it's being shared with the world. And so our view of what is normal and not normal is starting to be spread around the world. And so it's a book called Crazy Like Us. You may have heard the term running amok. It's a term that in American English, it means that we're just kind of going crazy, that we're just kind of acting wildly without any kind of appropriate end in mind. And so the thing is, though, is that there is this idea of amok, and it's in Malaysia, Laos, and the Philippines. And it's when a person is brooding, and then they have an outburst of violent, even randomly aggressive, even homicidal behaviors that they engage in. And so with running amok, we take it from Southeast Asia. Then there's this idea called koro, and this is in South and East Asia. And it is the sudden and intense anxiety that one's penis will shrink, or for females, the vulva and nipples, and recede into the body. And so this idea called koro. Then there is locura, and this is in the United States and Latin America. And this is people who suffer from chronic psychotic symptoms. It's just locura. And it's a Spanish word. And so when we're looking at these other cultural disorders and maladies, this is the beginning of a list. There are many more. And they're going to be particular to specific cultures. And the thing is that who gets to define what's normal? Who gets to make that diagnosis? Who gets to make that decision? Who gets to make that determination? And that's where we start getting into where we are with American psychology and American psychiatry. And here in the United States, there is this thing called the Diagnostic and Statistical Manual of Mental Disorders, aka the DSM, of the American Psychiatric Association. Now, the DSM has been around for a bunch of years, goes back to at least the 60s, maybe the 1950s, if I recall correctly. Up until June of 2013, it was the DSM-4 text revision. And so there's going to be there was the DSM-2, there was the DSM-3, and we had the DSM-4. So you have to know Roman numerals. And then now we're up to the DSM-5, literally has just been released in the year 2013. Now, that is what we use in the United States, is the DSM. The American Psychiatric Association makes the determination of what gets to be diagnosed and what are the symptoms connected with a particular diagnosis. And internationally, there's what's known as the International Classification of Diseases, the ICD-10, and that has a mental illness section in it. And so internationally, they will be using that. But for our purposes, for the AP Psych test, we only need to know about the DSM. Now, there are some criticisms of the DSM that have been leveled. One of them is that it's biased. It certainly is American-based. And because it is American-based, one of the things that we experience with that is an Amerocentric viewpoint of what's normal and what's not normal. And when we see some of the examples of disorders in other countries, we don't have those, so we don't diagnose those. And so it's going to be American-based. It's going to be biased because it's seen to be political. Now, one example of that is homosexuality. Prior to I believe it was 1973, homosexuality used to be defined as a disorder. But because of political pressure, homosexuality went from being a disorder to a non-disordered behavior in American culture. And there are some people in American culture who say, wait a minute, that is part of a particular political agenda, and that has no business being in medicine and in psychiatry. Another criticism of the DSM is that it overdiagnoses regular or normal behavior. There used to be this idea that little boys were squirrely, energetic little guys, and they had difficulty sitting still. That's what it meant to be a little boy. But now, we have what's called ADHD, Attention Deficit and Hyperactivity Disorder. Is ADHD an over-response to what is a normal behavior? And so, these are some of the criticisms that have been leveled at the DSM because it is created by a group of psychiatrists who are engaged in the practice of psychiatry, who work with people who have disorders. And because that is the case, they have a certain background and set of experiences, a set of schemas, if you will, to help them formulate what's going to be in the DSM. But there are going to be criticisms of the DSM. And so just the idea of labeling is going to be problematic for some people, because if you label something a psychiatric disorder, sometimes it's not covered by insurance. And that's one of the problems that we have in the United States in general, is that mental disorders, psychological disorders, are not seen or perceived in the same way as medical disorders. Because sometimes people will say, come on, you've got a particular disorder, just snap out of it. And of course, that's ridiculous to a person who's suffering from an anxiety or a mood disorder. It's an absurd statement, but that's the same thing that imagine saying, come on, you've got cancer, snap out of it. What's wrong with you? Come on, deal with it. It's a ridiculous statement, but because we treat mental disorders differently than physical disorders, than regular so-called medicine types of things, because we treat those differently, our insurance companies don't cover a lot of the things that are labeled as mental disorders. And so with the over-medicalization of and over-diagnosing, so to speak, that can create a perception problem and a reality problem, especially if someone needs treatment because of personal distress that they're experiencing. Now, there are the axes. It's a 5-axis system. And as a 5-axis system, the first thing is axis 1 is clinical syndrome. Is it present? Is a clinical syndrome present? And that's where we're going to see those slides coming up. Axis 2 is it a personality disorder, or is there mental retardation present? And yes, they still use the term retardation in official terminology. When we are looking at this particular idea, for AP Psych, Axis 1 and Axis 2 are the only ones we really need to worry about. Axis 3, medical condition. Axis 4 are these other issues. Do psychologists and psychiatrists have to worry about it? Yes, absolutely. Do we in AP Psych have to worry about it? No. The global assessment, we don't have to worry about that. So for our purposes, we only have to deal with Axis 1 and Axis 2. And the only thing that we deal with in Axis 2 is it a personality disorder? And so the thing is, though, and because of the way the AP tests are created, They probably have the next couple already in line, and the DSM-5 just came out. And so we probably won't worry about the fact that the AXIS system has been eliminated for a couple of years in terms of the 2014 test and the 2015 test. There may still be a question about the AXIS on it because it takes time for the textbooks and for the tests to catch up with the times when the DSM does change. In fact, it'll probably be 10 years before all the textbooks are caught up with, unless we move to all online-based texts. But it's going to be a few years before the DSM-5 is completely in all of our psych textbooks. So in Axis 1, the axis that we need to be familiar with, what clinical syndrome do we have? And so first we have childhood disorders, and you can actually take a course on infant and child and adolescent psychopathology. So mental illnesses in children and adolescents. Delirium, dementia, amnesia, and other cognitive disorders is another category within the axis, within Axis 1. Are these mental disorders due to a general medical condition? This is formerly known as an organic disorder. Are there substance-related disorders? Not something we deal with in AP Psych, but certainly something that psychologists and counselors will deal with. Schizophrenia and other psychotic disorders. We definitely deal with these. We also deal with mood disorders, depression, bipolar disorder, anxiety disorders, OCD, PTSD, somatoform disorders. And then there are what are called factitious disorders, and these are intentionally faked. We do not need to worry about those. Again, there are those categories we've already gone over, but these are part of Axis 1. Also part of Axis 1 are dissociative disorders, eating disorders, sexual disorders including gender identity disorder, sleep disorders, impulse control disorders that are not classified elsewhere, adjustment disorders, and other conditions that may be a focus of clinical attention. So in AP, we deal with some, but not all, disorders. So we look at it in some depth at, I think it's 7 categories, but we do not look at all mental disorders. And so what you'd want to do is, once you get into university, is take a course in abnormal psych. Ideally. That was one of the first university courses I took after my intro, and it was fascinating. And up until a few years ago, I still had my textbook that was still DSM-3 information in there. Then there's the DSM-3R, then the DSM-4, the DSM-4R, then the DSM-4TR. So it does change over time. Risk factors for mental illness. What things make us more likely to succumb to mental illness? Well, one is going to be social conditions, including poverty, homelessness, living in an overcrowded circumstance, stressful living situations, and social disorganization. So those are going to be social conditions, social factors. Then there are going to be family factors. Parents who are immature. This is one of the reasons why it's not good for teenagers to be having children, because they themselves haven't figured themselves out yet. And so it's difficult to care for properly children that you have yourself when you are that young, when you haven't figured life out yourself. When you have parents who are mentally ill, parents who are abusive, parents who are criminal, parents who have poor child discipline, and by discipline I mean structure, not that they hit their kids, but that they have structure for their kids. And also family factors where you have severe marital or relationship problems. Those are other factors that help increase the risk for us having mental disorders. Psychological factors, low intelligence, high stress, learning disorders, and a feeling of a lack of control or mastery over one's life. You start to see why so many people experience mental disorders now. Look at these factors. I mean, everybody probably experiences at least one of those. Then we haven't even gotten to all of them yet. Then we get the biological factors, genetic issues, defects, or inherited vulnerabilities. Perhaps there's a genetic predisposition for a particular disorder that if we have the right environmental stressors and experiences, that will trigger the genes to start manifesting themselves in our phenotypes. And that can be a problem. Poor prenatal care has been associated with some mental disorders. Head injuries, exposure to toxins, chronic physical illness or disability, exposure to toxic chemicals or drugs. And one of the things that goes on with that is there is a thing actually, when you do drugs, there's actually a thing called cocaine psychosis. And that's literally where a person, they will try cocaine. Maybe they've used cocaine 2, 3, 4 dozen times without a problem, but they take cocaine one time and boom, it triggers and changes the brain chemistry just right so they can go into a cocaine psychosis and they stop experiencing reality the same way we are experiencing reality. There are people some people who, because of their brain vulnerabilities, they will take LSD, not come back from a bad trip. There are some people who will take ecstasy, and because of the way that affects the serotonin, both producers and receptors in the brain, they will no longer be able to experience happiness and will go into a lifelong depression. And it can create problems for them. And so exposure to toxic chemicals or drugs. And then again, I repeat, for emphasis, head injuries. Now, whether you text and drive, I don't know. Please don't. Please don't talk and drive. And when you're driving, please just drive. I've seen too many people whose lives have been severely damaged or ended because of not paying attention while they are driving. And so head injuries, whether it's from driving, the son of one of my friends who I work with, her kid was skateboarding without a helmet. He died. I could give you horror story after horror story about people who have gone through these experiences. Believe me when I say they occur, and when you do things, take calculated risks and use safety precautions. Because the brain, as we saw in the brain and biology unit, the brain, although it's covered in the skull, it's a very fragile organ, and it's what makes you you. And if you lose part of that because you've damaged it, then you lose who you are. And that would be a shame, especially for something that is preventable. Labeling psychological disorders. There's a guy named Rosenhan, and you need to be familiar with him. And on the Discovering Psychology series, he's on there and he says, several colleagues and I, we went to particular mental hospitals complaining of the symptoms of hearing the voices that said empty, dull, and thud. That was it. We simply said we had those symptoms. We were admitted into those mental hospitals, and then once admitted and on the wards, we then acted completely normally and no longer complained of any issues. And so they heard the empty, dull, and thud. They heard the voices. Well, hearing things, having hallucinations, it was one of those circumstances where that they were diagnosed with schizophrenia. And one of the things that they discovered was that even though they were released and having no symptoms for 30 days, they were still diagnosed and still labeled with schizophrenia in remission. It didn't mean that they were completely cured. It means that they had the diagnostic label and it will stick with them forever, was the idea. But one of the things that they really got out of that was how dehumanizing an experience they had in the mental hospital. Because what you have are human beings who are going through challenging circumstances. Do they have visitors? Usually they don't. In fact, he said that his wife's visits counted for like 80% of all the visits on the ward over the period of time of that month. So do they have visitors? Not very often. Do they have goals and dreams? Probably. But because of the dehumanizing experience of living in a drab, dank, dark location, and then because you get the psych techs, They're typically people who may have been psych majors, but they oftentimes have an incredibly difficult job. And after a while, in particular jobs, there's a huge opportunity for burnout. And because there's burnout, the patients would often get treated very poorly. And so there's this dehumanization that goes on in too many mental hospitals. Because especially at state hospitals where it's taxpayer funded, and you know that we as taxpayers, we don't want to pay for anything. We want everything handed to us, but we don't ever want to pay for it. So that's going to be part of the Rosenhan study, and what we get out of it. It was the dehumanizing experience of being in there. But also the power of labels. Because with the power of labels, the preconception can stigmatize. So do we talk about the person with schizophrenia, person first, with the label, with the diagnosis, or do we talk about the schizophrenic? Which label do we use? Which wording do we use? Does that wording change our perception? So the schizophrenic versus the person with schizophrenia. How does that change our perception of the person, of the circumstance, of the disorder? Because with the labels, people will have trouble finding jobs. Yeah, what's that gap in your resume about? Yeah, well, I spent a year and a half in the local mental hospital. Oh, really? Okay, thank you. We don't have any jobs right now. Struggle to find places to live. And, of course, struggle to find friends. There is a very, very strong stigma in our culture about mental illness because we don't know very much about it. We tend to be afraid of it. And because people who have mental illnesses are different, we fear that difference, and so we want to just push it away. However, labels can be helpful for treatment. So, for example, if it's accurate. But oftentimes, there is a kid who is labeled as ADHD, but then later on, what they discover is the child actually had childhood bipolar disorder. So diagnoses are potentially tricky things. We're going to deal with the insanity label because that's a legal term. Stereotypes of the mentally ill. They're violent. They're dangerous. They're scary. And that's the case because of the media coverage. We get the people who have a mental illness of some sort. We get the extreme people who act out in a violent way, and they're the ones who get the attention. Whether it's the guy who shot up the Colorado movie theater, or the two boys who shot up not too far at Columbine High School, the man who did the shooting at Virginia Tech. All these different shootings and violent actions, we find out that there's some mental illness involved. And so we make that illusory correlation, this connection that, oh, people who are mentally ill, they must be violent. They must be dangerous. The reality is that the vast majority of mentally ill people are people you know and see every day. People fighting their own internal private struggles that they don't want to share with you for fear that you will not be friends with them anymore because they happen to have a particular struggle. And besides, when at any given point in time in a year, 20% of the population could be diagnosed with mental illness, that's 1 out of 5 people in the United States in a given year. So most of the humans who are alive in the United States are not violent, scary, and dangerous. So the stereotypes are potentially incredibly dangerous themselves. And then, of course, there's the idea of self-fulfilling prophecy, which we will get to in the social psych unit. But that our behavior towards someone alters, and of course I'm having trouble with my spelling again, alters, T-H-E-I-R, alters their behavior. And what that will do with the self-fulfilling prophecy, confirm our bias. And so if I think someone is going to be dangerous or scary, I might act in a defensive, aggressive way toward that individual. If I act in that way toward that individual, they're going to respond to that, and they're going to respond with some anger. And you're going to like, oh, geez, that I knew they'd be scary. You know, look at that. Look how they're acting. Yet little do we realize they're responding to our behavior. Insanity, as we mentioned before, there's a definition for it. It is a legal term, and it reflects an inability to manage one's affairs or to be aware of the consequences of one's own actions. So although psychiatrists and psychologists are used in determining if someone is insane, this is a legal term. And so those people who are judged insane by a court of law are not held legally accountable for their actions. And so I know in Batman you've got the Arkham Asylum for the criminally insane. Places do exist. They're called criminal mental hospitals, and it's where people have been violent and committed criminal actions, but they have been judged to be insane, and so they don't go to prison, they go to these mental hospitals. Sadly, too often, our prisons now, because we don't have the national facilities to deal with mental illness that there is, people who have mental illness will go to prison instead of going to hospital like they need to. And so there was an article I just literally read and then tweeted the other day. I think the title was something along the lines of, is our prison system our de facto mental health system? And there was a lot of evidence to suggest that that was actually the case. Now, with insanity and this idea of having the inability to be aware of what you're doing, you can be involuntarily committed to a psychiatric hospital. In California, that's called a 5150, or being put under observation for 72 hours under psychological watch because you're potentially are deemed to be a danger to yourself or other people. And so this idea of insanity, we have to look at it. How accurate is it? There's a film called Primal Fear with Edward Norton, and he somehow fakes multiple personalities in order to not be found guilty for a crime that he committed. Fascinating film, good film to watch. I'm glad I watched it once. It's not one that I want to watch again, but it's definitely worth watching once. Edward Norton is a fantastic actor. But it deals with mental illness and this idea of insanity. So how accurate is the judgment? Because it is a judgment. And so one of the things that is going on today politically is that some are moving to try to abolish the insanity plea and the insanity defense because they say, irrespective of someone's mental health status, they want to make everyone accountable for their actions. So that is an issue that's out there, not something we delve into in AP Psych. Something that you're going to see multiple times in this unit is we've got the DSM, and we're going to be looking at the category of a disorder. And so categories are going to be anxiety, mood, schizophrenia, somatoform, and some others. Then we're going to look at disorders. So PTSD, OCD, severe depression, bipolar disorder, schizophrenia. So names of disorders. And then symptoms. And we're going to have symptoms like tension or irregular mood or severe mood swings. So these are going to be some symptoms that we will see. So we're going to have to distinguish as we go through these disorders, distinguish between symptoms, disorders, and categories. Categories, disorders, and symptoms. And so I'll be making lots of references to this idea in the issues to come. So to review, how should we draw the line between normality and disorder? What perspectives can help us understand psychological disorders? How and why do clinicians classify psych disorders? And why do some people criticize the use of diagnostic labels? So these are some issues that we're starting to get into and starting to delve into. And one additional question. What is insanity, and is it psychological? So that's our intro into abnormal behavior. Thanks for watching AP Psychology here on Educator.com.